Okay, hi guys. I'm going to just finish up this localization PowerPoint. So, what I want to say is just to remind you, we are focusing on the beam for this localization technique. So, the direction that the beam coming out of the tube head is going is the direction that any buckle object will move as well. That is opposite from the slob rule because that focuses on the tube head, and they're going to basically move in two opposite directions. Um, so, chew on that until you feel really comfortable about it. And of course, you can ask me questions. But for the way we do this buckle object rule, we focus on the beam coming out of the end. So I wanted to reiterate that. And then I'm going to fast forward till we get to, we talked about some buckle landmarks, basically. So vertical and horizontal angle changes, we can see variation in the root length, and we know that from our principle of elongation and foreshortening. We see that we can elongate a root and we can shorten a root, and that's vertical angle changes. The movement of the cusps and the root, they tend to go with the direction of the beam because the buckle cusps will tend to kind of bend or stretch toward the direction of the beam, and the same with the roots. The zygomatic process, that's either going to kind of lower, come down, just like you guys have been looking at those anatomy handouts that I gave you. And remember, I said that I did so many different zygomatic process pictures because the zygomatic process shows up so differently depending on the vertical angulation. It might be higher up in the x-ray, it might be lower down, and it just is shifting based on the vertical angulation. Movement of the external oblique ridge, same thing. It might come out kind of lower on the crown, or it might come up higher on the crown. And that again is just as you change the vertical angulation. So the roots tilt in the same direction as the beam. We can see that here in these images. They just kind of lean, one way. But notice how the palatal roots kind of coming a little bit more straight up and down, where the buccal roots are sort of tilting a little bit more. And that is because the buccal roots are going to be more affected by the beam, and the palatal root is going to go the opposite direction because it's more lingual. Buccal cusp, always closest to the edge of the film. All of these lower cusps are the buccal cusps, and you can really see it here. See how the buccal cusps are kind of heading this way, where the lingual cusps are kind of heading that way. And so that's the same thing. But it only works in the posterior. That doesn't work in the anterior. Objects that are located buccal always move in the same direction as the beam. So we can take this example of this anomaly, whatever this is, and we can take that example and we can look at it and we can say, well, from this image that's sort of more straight on, we can see the buccal cusp is more straight, the roots are more straight up and down. And then when we look at this second image, we see that the buccal cusp veered posterior. The roots are veering posterior. But we notice that this object moved from in between these two teeth to now it's over the premolar. So the object moved mesial, but the buccal objects moved distal. So that helps us know that this object is actually located lingual to the teeth as opposed to buccal to the teeth. So that's where it's embedded. It's actually more lingual. So the bottom, the buccal cusps of the first premolar move distal to the lingual cusp compared to the baseline X-ray. And this is our baseline because it's a more straight on version. So angle changes, we can look at, just like I was saying, we can look at the cusps, how they change, see how it's straight up and down, then it's tilted off more posterior. So we can see how those cusps change. We see how the supernumerary tooth moves and how it's moving opposite from the direction of the beam. Works only in the maxillary molars, but the two buccal roots and the one palatal root, you can really see how it shifts. So here we have these buccal roots are sort of more straight up and down, or maybe even leaning a little anterior. The palatal roots kind of leaning more posterior. And as the beam shifts, the palatal root moves anterior. And so we know that from this film, which we could call this film our buckle, Or we could call this film our baseline. From this one, where the cusps are all kind of straight up and down and the palatal root's kind of straight up and down, the palatal root then moved posterior and the buccal cusps moved anterior. So that we know that from this shot to this shot, the beam was moved more mesial or more anterior. And our biggest clue is that this palatal root moved posterior. So if they moved in opposite directions, then we know that the one that moved opposite is palatal, and we already know that that's a palatal root. So we didn't have to figure that out, but that proves the theory. Sorry, my nose is running, so I have to get a tissue. Um, so here is another example of the movement and how we can decipher based on a buccal landmark. So we know our external oblique ridge is a buccal landmark, and see how it normally, we always talk about it like coming straight out the side of the last molar. Well, if you look at this film here and you see this tooth and you can see a root back here. And when you look at this one and you compare it to this one, where now look where the external oblique ridge moved. It moved from down here below this amalgam filling, and it moved all the way up toward the top of the tooth. Now that's just an angle movement, but what came with it was the root of this tooth. So because that root moved with the external oblique ridge, we know that these roots are facing more buccally and that the actual crown is facing more lingual. So this is just describing it. Bottom, the ridge crosses the distal of the second molar. The top, the ridge crosses the middle of the second molar. Root of the third molar shift forward from bottom to top. That means the roots move in the direction of the beam. So we know that the roots are more buccal and the crown is more lingual. The external oblique ridge always is buccal to the teeth, and so that's the clue that we're going to look for. It's always, always, always buccal. And we've talked about that. We can even look at it on a skull, and we can see that the external oblique ridge is on the front of the mandible, and our internal oblique ridge is on the lingual, or it's also called the mylohyoid line. Mandibular canal is variable. It just sits inside of the mandible. So we don't know, maybe some people it's more buccal, some people it's more lingual, but we can't use that as a guide because it's too variable. We don't know where it is. So vertical movement works very similar to horizontal movement. In the diagram at the left, the buccal, which is the yellow, and the lingual triangle, which is the red, objects of interest, they're superimposed over each other when the beam is coming in very perpendicular. But if we change it so that our vertical angulation either steepens or becomes more, either goes down or comes up at a steeper angle, that's going to move the objects. And so here you can see that with a downward direction, our buccal object moves down and our lingual object moves up because it's going to move in the opposite direction of the beam. And then we can see how it works in reverse. If our angulation is a negative angulation, then it's going to move our buccal object up and our lingual object down because it works. The buccal goes with the beam, the lingual goes against the angle of the beam. I love this picture because it shows the zygomatic arch and it shows how the angle of your X-ray beam will change where it shows up. So if you have a very steep angulation, if your target ring is way up here, you're going to pick up more of that zygomatic process, and that you can see that clearly in this picture. The whole cheekbone and the zygomatic process because we have a steeper vertical angulation. If we come in more flat, we're just going to clip a little bit of it and you're not going to see as much of the zygomatic process. So I just love this picture. It just shows it really, really well. Which radiograph is our baseline? Well, we know our baseline is the one that looks more straight on, less distortion. So our cusps are closer together, our contacts are open, everything just looks kind of more like it came in more at a perpendicular angle. And so this is after the beam got changed. So one thing we know is that it steepened, the angle became more steep. So it went from being more flat to more steep. So if the vertical angulation moved, basically the beam moved down more, then we would expect this tooth to also move down if it is a buccal impacted canine. But if it's a lingually impacted canine, we would anticipate it to move up. And that's exactly what we see. From this position to this position, it moved up. So it moved away from the direction of the beam. So we know that this impacted tooth is more lingual. The vertical angulation movement of the external oblique ridge is also still apparent here. And this is, again, just kind of showing as you change your vertical angulation, the external oblique ridge is going to change from look like it's coming out, maybe lower on the crown to look like it's coming out higher. Just like this, we have it lower on the crown. Now it's coming out higher of the crown. And it's just the way it is visualized because of the angulation of the beam. So which radiograph is our baseline? Between these two pictures, it's kind of a guess which one is our baseline, but I would take this lower one as the baseline, and then we would look to see which direction did the external oblique ridge move. Well, it moved up, and so now also, can we see something that has changed with this impacted molar? Yes, we can see the roots also moved up. So because the roots moved with the external oblique ridge, we know that those roots are facing more buccal and the crown is facing more lingual. This one is a lot harder for me to explain and to even kind of wrap my head around. So I really dislike this example, but I'll do my best to try and kind of process it here with you guys. This film is more of a central incisor film, right? It's not really a canine shot. We have the two central incisors and the laterals. We pick up a little canine over here. But this is a very different shot than this. This is a canine shot that's a little wonky. So it's hard for me to feel like this is a good explanation. But we have this composite, and we're trying to figure out from this more kind of straight on what happens with the composite. So when we look at this, we can see the tilting of the roots. We can kind of say, well, the roots are all sort of tilting this way. And the composite moved from sort of the distal part of it, like way over to the buccal side of it. So that would lead me to rationalize that this is probably a buccal restoration because when it was straight up and down, it kind of looked like it was wrapping a little bit more to the distal portion of this tooth. I think this is tooth number 8, right? But then as the roots tilt sort of more to the midline, this restoration goes way with it, right? They go with the tilt of the roots. So this is leading me to say this is a buccal composite restoration. And of course, I'd probably be sitting in the chair and I could look in the person's mouth, but if we don't have that clinical observation, that's how we would try to rationalize it out of these two films. This is another tricky one because again, we're looking at a canine film as opposed to a premolar. So now we're trying to decipher which one is the buccal root or canal and which one is the lingual canal. And so at if we look at this picture, we can see, I'm trying to think of what I will use. The arrow in the canine film is pointing to gutta percha. In which canal is it pointing to? And, we can see our cusps and everything. This is our baseline film, and everything is sort of going straight up and down. Now, what I would say is we need this premolar film, but we need our angle to have significantly changed. And then we can see this separation. But when you move from this to a canine shot, I feel like it's hard. I want to say the roots all sort of look like the ends of the roots all sort of look like they're leaning a little bit posterior, and that this one is going way anterior. So I feel like my instinct is telling me that this is a lingual canal, but to be honest, this is a hard one. So I don't readily feel like this one is as easily is as easy to demonstrate this theory on these pictures. So I'm not a big fan of this one. But here's an explanation. So here we go. I forgot this was the next slide. So when the beam is moved distally, so when our beam is pointing more toward the posterior teeth, the two canals, which are initially superimposed, they separate, and the buccal canal, which is the blue arrow, will follow the beam movement, and the lingual canal, which is the red arrow, will go in the opposite direction. So I guess I guessed right, even though I wasn't confident about it. But I think now that I see this slide, I think what's happening is, as we start in our central incisors and we move around the side of the mouth, we tend to aim the beam. The tube head gets angled more mesially, but the beam goes more distally, just like you see here. And so they're saying, from here to here, we know it's more straight on, and now the beam goes a little more distal, and then this canal moved more anterior or more mesial. So I guess that this is just more complex, though. That's a higher order of thinking, and I struggled to try and get it right. So, but that is, I can see the rationale better, but it's still harder to pull that out from just those two pictures. Okay, so how does this apply to me? Last couple pictures, I really want you guys to get this. Look at this picture. So we've taken a picture on a human being. This is a real mouth that was taken in our clinic. This person has a first molar, second molar, and a third molar. And we want to see that third molar, but this person is gagging. So we take this picture. We see our contacts are decent, but we don't really see the apices are kind of missing. And we definitely don't see that third molar. So we take another picture, we change the angle, and we get a little bit farther back, but we're still missing a huge amount of information back here. And we're getting some more foreshortening and distortion, but we really want to figure out how do we get back here more without having to shove our sensor all the way down our patient's throat. And then what we do is this picture is probably the exact similar placement of the sensor from this one. We've just probably changed our angulation drastically. Look how much foreshortening is in this tooth. It looks very different from, say, this one. Look how long these roots are. So, these roots are super duper long. And then as we foreshorten it to try to get more of the teeth, look how much foreshortened they are. So it causes a lot of distortion, but it allows you to get that tooth on film without choking the patient. Now, some people will let you put a sensor back farther, but some people won't. So this is a really wonderful way to use this kind of localization technique to change the angle and capture something that you might not be able to capture other words. So I do want to practice this theory more, hopefully, not next week, but the week after. We'll put this into some practice on Dexter. And that's all. Hopefully you guys will watch this and the localization technique will make a little bit more sense to you.